It's a complex, high risk and indicated PCI. And basically we are dealing with, I think, surgically turned down cases, which are increasingly prevalent, commonplace in cath lab, and there is a momentum for more complex interventional procedures, and you need expanding skill sets and a timely opportunity to better examine the outcomes and informed clinical decision making, and one of which is whether you should do a complete revascularization or a focused revascularization. I think this slide has been put up by Dr. Samin Sharma, the complex multivessel disease, which will include the anatomy, post-distal target diffuse disease, and severe calcification. We heard a whole lot of them, and comorbidities are very important: advanced age, fragility, and morbid obesity, and the hemodynamic state. Now, complete versus incomplete. Let me tell you that there are no RCTs in this niche population, but I think our wisdom should prevail. But because there are no RCTs, I think we can argue till the cows come home. And if I personally believe if one is using a mechanical support device, then probably complete revascularization will give cost saving also in India, and of course better hemodynamic outcomes. So my paradigm will be higher the risk, more complete the revascularization, and higher the reward. Now just talk on a patient, 71-year-old male, class 3 angina. He had an NSTEMI in 2018. He had diffuse RC and LAD lesion, calcified, and failed first attempt. You can see the RCA. Yeah, it is a calcified vessel, and that was the LAD. And see diffusely diseased LAD after a major diagonal. So we had decided to go in for a rotablation to the RCA. Yeah. So this is after the first run, and then balloon dilatation, and then stented off with a promise stent, and there was a rather okay result. Then the LAD, it was, we did some runs, some 3 runs with a 1.25 bar. It was a bit difficult because it was a tortuous LAD. And then finally we managed to push down a 2.75 into 28 science expedition stent. And that was the outcome, which was rather okay. And this was, I think 4 years ago. He still comes for follow-up and is doing well. Now, the optimum data which is presented from TCT 2021, outcomes of percutaneous revascularization for management of surgically ineligible patients with multivessel or left main coronary artery disease. Now, the cohort was 750 patients, of which 726 underwent PCI in 22 US centers. They were deemed inoperable by the heart team. These patients are systematically excluded from all clinical trials. And why were they excluded? We don't know. Maybe poor distal targets in around 19%, severe LV dysfunction in 16%, advanced lung disease in 16.8%, and frail or advanced stage in 10.1%. And the outcomes, they looked at the primary and secondary outcomes, 30-day and in-hospital mortality, and they compared it with the predicted STS surgical score and compared with the Euroscore. Euroscore 2, and also compared with the local surgeon's predicted risk, and quality of life assessment was also done. So the inclusion criteria is, it's all there. Now exclusion, they excluded ST elevation MI, ventricular arrhythmias, hemodynamic instability, and expected survival less than 1 year. So this is the hemodynamics, mean age of 70 years, of which 31% were females, large number were diabetic. In a US population, 56%, prior MI 48%, prior PCI in 32%, prior CABG in 16%. So rather high risk population, and 23% were NVHA class 3 and 4. So the heart team had deemed inoperable, and they have been taken off for CHIP, and they have looked at the in-hospital and 30-day mortality. Now the lesion characters, bifurcation in 80, CTO in 57, mean syntax score of 33 in 45%, LM disease in 38%. And you can see here, even in the US, the mechanical circulatory support was used only in 27%. And IVUS use was rather high in this cohort, about 63%, and complications were 9.8%. Now look at the 30-day mortality. It was 5.1%. So, and this is same as the STS predicted mortality of 5.3%, and the score, 2 predicted mortality of 5.7%, and surgeon predicted was 10.4%, and mortality at 6 months was 12.7. Quality of life, 80%, and no angina at 6 months. Now, however, now you are given a license to do chip PCI, but moment to chip PCI should not be taken lightly. You have to ensure that the procedure is safe as much as possible. Patient is in the best of hemodynamics, in the best of renal situation. Discuss with your team, not only the heart team, the renal team is also very important, your critical care team, etc. Now, I'll show one case of an 85-year-old male who came to us with recurrent episodes of acute decompensated heart failure and pulmonary edema. His ejection fraction was 36%. Serum creatinine was 3.6. And then I showed him to our nephrologist. He said, hey, Dr. Sunitha, you please fix the coronary lesion for me, otherwise I cannot tackle his renal. And this was, you can see, that is a large diagonal and LAD, heavily calcified. Again, heavily calcified lesion. RCA was normal. And his ejection fraction was 36%, but viable myocardium. So we wired both the LAD and the diagonal was not calcified. As you passed the balloon, you knew that it was not much of calcium. We stented it because the IVL comes with a free 2-stent package of the Vivo ESR, and then the LAD. And this is the run, pre-run. You can see that the LAD, the tightest part, was showing a circumferential calcium of I think it was, the area was, yeah, here it was 2.2 there, and very tight, and very circumferential calcium, very heavy calcium also. So we decided to, the LM was also calcified, that's a proximal LAD, and then the LM. So, okay, so we decided to give some IVL runs. So IVL was used in the LAD, and in the osteoproximal LAD also. And then we gave dilatation with non-compliant balloons, and then repeated the IVL, but unfortunately we could not see any cracks as such in the calcium, but there was some improvement in the area. Some improvement in the area was definitely seen. In that mid-LAD, it had gone to 4.3 millimeters squared. Just run it fast. Okay. So we were little hesitant, but then we decided to stent it, and we stented the distal LAD with a 2.75 into 18 stent. Then we took a 3.5 into 38 stent from left main, mid-LAD to the left main, and blew it up. And this was the osteoproximal LAD. Area was good, and the distal left main was 8.1, which is 4.3 earlier. And then we found that while we were post-dilating, there was a plug shift to the diagonal. So we did a kissing balloon also, and this is the final injection, which showed that there was pretty good flow both in the LAD and the diagonal. He remained hemodynamically stable during the procedure, and he made an uneventful recovery. Our nephrologist was quite happy. He said that he can take him up for dialysis later on if required, and 100 ml VCPEG, but I think that is too much compared to what you talk about zero contrast angioplasty. But still keeping our fingers crossed, he has been discharged and doing very well. So now the non-culprit disease in this chip PCI group, when to do, what to do. It is it's a focus of clinical research. We don't have data. We know that in chronic CAD, complete revascularization is associated with lesser mortality, both in PCI as well as in the CABG. And in primary, of course, we have enough data. That is in the primary PCI, we have enough data. The primary has shown significant reduction in death MI and in refractory angina in the STEMI population. Again shown the culprit also with STEMI with more than 70% lesion in the non-culprit vessel. They did well, and there was a change in the ACCHA guideline. And the ESC also has put a class 2 indication, class 2A indication, routine revascularization of a non-IRA can be performed before discharge or along with the index procedure if the patient is hemodynamically stable. Now this is the follow-up of the complete trial. Again, you can see, say, the number needed to treat is only 13. Now, what about a complete revascularization in stable CAD? It is intuitive and logical to accept that complete revascularization will be advantageous than incomplete revascularization. CABG small trials have shown in chronic CAD, there is even a survival advantage. In non-STEMI, a single stage or multi-stage or a culprit-only PCI, there was this, I could fish out this trial, and they looked at the impact of different strategies in this cohort, and one stage versus multi-staged, 548 patients. And they looked at MACE and cerebrovascular events at 1 year. And what is surprising was that the primary endpoint was more in the multi-staged procedure. So multi-stage procedure had more MACE as well as even the cerebrovascular events. Now this is another study from the South Korean group, JAMA, July 2020, retrospective observation study. And again, you can see that the complete revascularization versus multi-staged procedure, the hazard ratio is 0.74. So you find that, and the complete revascularization versus multi-stage, again, you find the very high, I think the complete revascularization is much better. But there is no difference in the one stage versus multi-stage. But if you use the gray score, you find that the one stage lowered the MACE much more than the multi-stage. So what about complete revascularization in CHIP PCI? Taking cue from the STEMI PCI data, from the non-STEMI data, the chronic CAD data, these complex, high-risk, interventional PCI patients may not give us another chance to improve their outcomes. And therefore, complete revascularization, one stage whenever possible, is certainly the way forward. And I humbly rest my case, and thanks for the kind attention. I have a very powerful opponent, I know that. Thank you very much. You would all agree that is too dramatic debate. And I know, so he spoke about a lot of things, but to me, a significant vessel is a vessel which is 2.25 or above. And if it is subtending a viable territory. So probably I would go ahead and do that. And of course, viability is extremely important because I personally look at all the echoes and make sure that it is viable. And then only I go ahead. But your points are well taken. About the trials that you mentioned, I think a little lopsided and little unfair also, because you said one trial in 2004, which is not correct. We have the revived data, which has come, and the confidence interval is 1.1. Okay, 0.74 to 1.1, I think is a very good confidence interval to say that, of course, that complete revascularization is good. Well, if you ask me in secret, I might say that, sir, I might also stage and do it. For the case which I showed, that 85-year-old gentleman, I had to sweat it out for 4 hours because no stents were going because of heavy calcium. I had to use guide liner, Guidezilla, then gave 60 pulses, and then that point of the critical lesion was not opening, so I had to go to 8 atmospheres and open it at risk of perforation of the lesion. But I think once you've embarked on a procedure, on a PCI, we have to complete it. We have to complete it and give the best results for the patient. So thank you all. Yes,
I have a question. Yes. Because in complete revascularization, residual syntax score is very important because that decides whether the patient has got recurrent events on MACE. So this complete revascularization or low residual syntax score, less than 8 is acceptable. More than 8, is it because people fail in opening the CTO? What is your comment on that?
Well, it could be, see, in CHIP PCI, you need all sorts of skill sets. So, because you may have to open a CTO also, you may have to hold Pratap in between to do a retrograde and do that for you. It's extremely important. So sometimes you will have to do the CTOs. And I think that is one of the reasons of commonest reference for CABG is a CTO. All agree.
And another thing is, in stitch trial, routine viability assessment has been found to be not much of use. So in CHIP PCI, is routine viability assessment is important?
I think so, because even in the stitch PCI, they have done viability assessment in all patients. In fact, they have done dobutamine MRI, I think. It was dobutamine MRI or dobutamine echo. I forgot the details. I presented it once. So they have done viability assessment and then only gone for the bypass surgery, and they found it is not useful. At the end, it was not useful. So it is there. But you know, when somebody is symptomatic, and who was in that particular gentleman, recurrent pulmonary edema, ischemia-induced pulmonary edema, refractory angina, you cannot leave them. You know, you have to offer them something. You know, I think even if it's your mother-in-law, you will offer something, Dr. Hasra. I'm sure you will offer something.
This debate is something similar to the STEMI, where you always think of critical versus, and probably now the trend is more towards doing the critical rather than doing a stage to revascularize. The only problem that we have in this situation is that very often if you do only critical, I side a little with Sunitha, because if you do a critical alone, especially in our country, because of the cost constraints, very often the patient may not come back to you again. So you are left with a patient who was partially revascularized. That point I think you would agree with me. But the completeness of revascularization is what determines the end points in all the trials, whether it's CABG or this thing. So I think that is a practical point which I have to say.
I think that is what was shown in that Korean data also.
He may not come back to you again in two ways. Either he has gone to heaven in the first chance, or he has gone home. So all depends on your skill.
So I think your idea is to prevent him from going to heaven, isn't it? So
I think what we have discussed and debated is an important issue. And I really like the only paper which I think makes sense in this whole area, which is pretty exhaustive, is the BCSS paper.
Yes.
On chip. And what is interesting is we cardiologists never have a Euro score. We never have an STS score. We only have a syntax score. And the syntax is simply a coronary score of angiography. And unfortunately, in chip, if you look at the scoring, 3 goes for usage of a pump or MCS or a poor LV. 2 goes for age, CKD, peripheral vascular disease, and EF of 30% or lower. Not a single coronary anatomy has 3 or 2 score. So your coronary anatomy, what we are talking about in revascularization, is all 1 point. Now that gives the importance of the comorbidities and the LV function, which is the issue in most of this chip. Now this makes it very difficult to decide how to fix these patients, because these two, that is LV dysfunction and CKD and age, the more dye you inject, the more time you take, the more prolonged your procedure, you're going to get into trouble. And your bleeding risk also goes up in those patients. So I think it's important that we make a very calculated decision. I would be different in a 50-year-old guy with multiple vessel disease. His kidney function is okay. I may be more aggressive, get after as much ischemia as possible. An 85-year-old guy who comes with multi-vessel disease, which is very common, calcific vessels, I want to fix the most important one and get out and get the patient out quickly. And I would sort of differentiate these patients because their renal risks are higher, their heart failure risks are higher, and their stroke risks are higher, and their bleeding risks are higher, and their kidney disease is an issue. So I think this is a very complex debate. We don't have a randomized trial, and I don't think we'll get a randomized trial in this group of patients. We have to use our wisdom in this whole story, and I think both speakers did a good job trying to present their point of view. But I think a balanced view in these patients is extremely important in this very high-risk subset of patients, however good an operator you may be. Thank you very much.
Thank